Okay? This is a lecture for orthopedic nursing. We all know that post-operatively, if a patient comes out having had a gallbladder done, or having had a hysterectomy done, or having had any kind of abdominal type surgery done, that the treatment is pretty much the same as far as orders are concerned. However, orthopedics is kind of the exception to the rule. A lot of nurses don't like orthopedics because it's full of instruments and full of prostheses and full of all kinds of rods and screws and plates. And most of the time in a small hospital, if you're working on the floor, a nurse may get to see a knee replacement or even a hip fracture, maybe only once every 2 or 3 months by the time that she gets to treat the patient again. And so there's a lot of questions that are involved. Different patients, but they have the same surgery. The patient is admitted with a hip fracture, and yet there's all kinds of different orders. Why are the orders different? Why is the weight-bearing status different? What are all those contraptions for? And why are dressing orders varied? And that's what we're going to talk about a little bit today, as far as the orthopedic nursing for the orthopedic post-operative patient. We're going to talk about hip fractures. We're going to talk about hip replacements, total hip arthroplasty. Knee replacements, total knee arthroplasty. We're going to talk about ankle fractures and a little bit about wrist fractures. Hip fractures are mainly of 2 types. They're either subcapital, or they're intertrochanteric. And both are treated differently and both are nursed differently. As far as the subcapital fracture is concerned, the anatomy is that this is a 3-dimensional picture of a hip. Here's the acetabulum, here's the ball, the caput of the hip, the neck, and the trochanter. That's a non-displaced subcapital fracture that we see on 3D MRIs, 3D CAT. The anatomy of the femoral head and the femoral neck. Again, you see the head. That's the head of the femur and the neck of the femur. Femoral neck fractures are just that. They're fractures through the femoral neck. Or subcapital because they're below the caput of the head. They can be displaced or non-displaced. And depending on how we find the patient preoperatively is going to determine what we do during the surgery and how nursing is going to treat it postoperatively. For a displaced femoral neck fracture, the patient will get what we call a bipolar prosthesis. This is 2 separate pieces, but they snap together and become one. The stem goes down into the femoral canal, and in the older patients it's cemented into the femoral canal so it won't move. And the ball goes into the socket and all the movement occurs right here. So this will stay in the socket while this moves, and the patient has a stable hip. On X-ray, this is what it looks like. There's your bipolar cup on top, and there's your stem going down into the canal, and all this white stuff you see surrounding the stem on X-ray, that's the cement that we've cemented in place. So you have a stable hip. You've just replaced the ball that was made of bone with a ball now that's made of metal. Non-displaced fractures. Here's the fracture right here, but it's not displaced. It didn't knock it off, it just kind of squished it down. Oftentimes I'll explain to the family, it's like taking a piece of ice cream on a cone and squishing it down on top of the cone, as opposed to knocking it off the cone, which is a displaced fracture. For a non-displaced fracture, all we have to do is hold it in place while it has a chance to heal itself. We don't have to replace it. And what we do is we put 2, sometimes 3 screws up across the fracture to hold it in place while the bone itself heals. Here's the fracture. Now, non-weight bearing orders. You'll often see non-weight bearing is 0%, toe touch weight bearing, or sometimes TD, touchdown weight bearing, is 20%. Partial weight bearing is 50%, and full weight bearing is 100%, or as whatever the patient can tolerate. And physical therapy knows how to instruct the patient on all these different percentages of weight bearing. That's why you'll see, that's how we abbreviate it for all these patients. So, back to you guys, nursing for the subcapital fracture. All right. If it's displaced, and if we do a bipolar replacement, we can allow the patient to full weight bear because we've replaced the entire thing. There's nothing that has to move in there anymore. It's all just been replaced by something that's metal instead of bone. We do a long posterior incision, and this will be the only thing because enough you'll see my description. But the posterior incision, if you've ever dressed it in the room, it's a long incision in the back of the hip, and the worry for us and the worry for you is dislocation. The back of the hip is the most unstable. So if the patient flexes their hip, if they bend their knee up and go to cross their legs right after the surgery, before everything has a chance to heal, which is about 6 weeks, they can dislocate the prosthesis just like you'd dislocate a hip in an accident or anything else. So we must watch flexion, and we must watch adduction or crossing the legs. That's what will dislocate the hip. That's why these patients come back with a knee immobilizer. All the knee immobilizer is doing is preventing the patient from flexing their hip and from crossing their legs like that with the hip flexed. Therefore, you try to prevent the patient from dislocating their hip. Now, the knee immobilizer only has to be used when the patient is in bed. I had a patient that I sent to a nursing home recently, and they called me saying that the patient just wasn't getting any better because when therapy got them up with that immobilizer in place, they just couldn't do anything. Well, they're not supposed to. The instructions are just to have the knee immobilizer in bed when they're sitting up in a chair or when they're up with physical therapy. No, they are not supposed to have the immobilizer in place. Now, if it's a non-displaced fracture and we just put screws in, they cannot full weight bear because you saw how small the screws were. You can break the screws, or you can pull the bone right out of the screws, and then we have a problem. So they cannot full weight bear. There will be a small lateral incision, only 2 or 3 inches long, as opposed to the big posterior incision, because it's a whole lot easier to put 3 small screws in than it is to put a whole new hip in. These patients will not have an immobilizer because we're not worried about them dislocating. We just need to hold everything in place. And we'll often say, even in recovery, put a pillow under their knee, and that's just for comfort. When you bend the knee a little bit with a pillow under it, you take the pressure off the muscles in the thigh, and it makes the patient more comfortable. So if we ever ask for a pillow under a knee, that's why. It's just for comfort. Now, the intertrochanteric fracture, the other type of fracture we talked about. Here's the intertroch, greater trochanter, lesser trochanter, and the fracture is back here. Remember, the other fracture was up here, but this is an intertrochanteric fracture, right between the trochanters. Whether it's non-displaced or displaced, we treat it the same way because we'll reduce it in the operating room and we'll make it non-displaced before we fix it. But the treatment is the same. All we have to do is kind of like with the screws with the other one. We just have to hold the pieces together. And if we hold them together, we'll let them heal on their own, and then the patient should do just fine. So we're not replacing anything, we're just putting everything in good position and trying to hold it in that position while we do it. These are the 2 types of fixation we use for the intertrochanteric fractures. Here we have a rod that goes down inside the bone, a trochanteric nail, if you will. Here's a big screw that goes up through here, up into the femoral neck. And here's a small screw that goes in here just to keep it from rotating. This is what we're using on almost all the patients now. This is by historical, this is what we used to use. It was a plate that would go on the outside of the bone with a hollow tube here, and here's the big long screw that would go inside the hollow tube. This is what it looks like on x-ray. The intertrochanteric nail goes down inside the bone. This prevents rotation, and this goes up inside the neck into the femoral head. Now this can slide. This can slide back and forth. So when the patient starts to put weight on it, they'll actually compress the fracture, which is right in here, as this bone slides a little bit backwards, compresses the 2 pieces together, and that's how the bone heals. As far as nursing the intertrochanteric fracture, as you just saw, we're not replacing anything, we're just putting essentially a big screw in there is what it comes down to. So they cannot full weight bear because the screw can cut through the bone, and unfortunately I'm going to show you an example of that in a little while. There's usually 3 smaller incisions on the outside of the leg. And again, we put a pillow under the knee for comfort, but we're not worried about dislocation. We haven't replaced the hip. We've only put a screw in there. Maybe it's a fancy screw with a rod attached to it or a plate attached to it, but essentially it's nothing more than just another screw. This is what happens, and we'll explain a little bit later how it happened. If you are not careful with what you're doing, here's the screw. Screw didn't move at all. Screw's nice and strong. But this poor osteoporotic head here, that did move, popped right out of the head, and the screw is now sitting outside, and the fracture is no longer maintained. That's what happens when you let them walk on it, by the way. That was done at a local nursing home that shall remain nameless, that said that Dr. Hennessy didn't know what he was doing. These people can walk on their hips. Whereas a lawyer wouldn't. All right. Bucks traction for hip fractures. When the patient is admitted to the hospital with most fractures of the hip, we'll say put them in Bucks traction. Why? It's only for comfort. It's to take some of the spasm out of the muscle in the thigh, because of course they're going into spasm because there's a fracture there, and the 5 pounds of Bucks traction just kind of gently pulls on the muscles of the thigh, lets them relax so they don't keep going into spasm and the patient's continually screaming in pain. So it's not doing anything as far as the fracture itself is concerned. It just cuts down the muscle spasm. If you have to adjust it, if you have to tighten the rope up or move it around a little bit, you are not hurting the fracture at all. We're going to fix the fracture at a later date. So don't worry about hurting the patient or hurting the fracture. Adjust it if it has to be adjusted. And please make sure that the weights are off the floor. There's nothing more frustrating than coming in and seeing a patient who's been 5 pounds of Bucks traction with 5 pounds sitting on the floor, adding absolutely no traction to the patient. You can shorten the rope, you can move the patient up in the bed, you can do whatever you want, but we need the traction in place. So, quick summary of hip fractures. Subcapital fracture. This is the one we replace. If we replace it, full weight bearing is okay. But if these people come back and we're not letting them full weight bear, it's because they have pins they're not replaced. Watch for dislocation in the patient that has a bipolar hip replacement, which will be in our note. Immobilize a while in bed only, not when they're up and moving around. And if we pin them with those 3 little pins, we can't allow them to full weight bear because you can break the pins off. Intertrochanteric fracture, same thing. It's a fancier pin, but essentially that's all it is. It's a pin or a screw. No full weight bearing. Pillow under their knee for comfort. And they may get some swelling in the thigh. They may come back with an ace bandage wrapped around their thigh, and that's just to prevent swelling for the first 24 to 48 hours. Total hip arthroplasty, or total hip replacement. Usually done for arthritis. Made up of 2 separate parts. It's kind of like the bipolar. The bipolar snapped together. This one doesn't snap together. They're 2 totally separate parts. So again, you're thinking, okay, if I'm replacing it, and now if you've even got 2 parts more than 1 part, we really better be worried about the possibility of dislocation. It's treated just like a bipolar. Watch for the dislocation. They'll be in a knee immobilizer. They will have a long posterior incision. But the nursing treatment is the same as it would be for the bipolar. That's what a total hip replacement looks like on x-ray. You've got a cup in here that's held in place with 2 screws so it won't rotate. You've got the ball, smaller ball here that is not attached to this, it just slipped inside of it. And the stem that goes down, in this case, it's not cemented, but you can either cement or not cement it. So you have 2 separate parts to the total hip. Total knee arthroplasty. Total knee arthroplasty, again, done for arthritis. There's 2 major parts. One goes on the femur, the other goes on the tibia. So you have metal on top, you have plastic on the bottom. You no longer have bone rubbing on bone. You have metal rubbing on plastic, which is not as painful. On x-ray, this is what it looks like. You have metal on top, and you have plastic. The plastic is in here. You can't see it because x-ray can't see plastic. And then you have it attached to the metal piece that's in the bottom. It's usually done for arthritis, as we mentioned. It can be very painful post-operatively, much more painful than a total hip, because the knee is much more superficial than the hip is. But we have a pretty good protocol that we work with now to keep most of this pain pretty much under control. The big thing with the knee replacement for nursing care post-operatively is to watch with sterile care of the wound. Because if we get an infection in the wound and we get an infection in the knee, it's a disaster. The prosthesis has to come out for 6 weeks. The patient is on antibiotics. Then they have to come back in for another major surgery to have another one put back in. CPM, continuous passive motion. You may have seen these patients in these gadgets. It's now a plus or minus thing. Most of the time now we're not using it. If we do use it at all, we won't start it for 24 hours post-operatively. It's kind of an ugly thing. There are slings that go onto here, cloth slings. The patient's foot goes here, their lower leg, here's the bend of the knee, and their thigh is here. It moves by itself, and what we do if we do use it is we increase it every day. You have 30 degrees of flexion one day, then 45 degrees of flexion, and then 60 degrees of flexion the third day, and so forth. It moves, the patient doesn't have to do anything. It just moves all by itself, and its purpose is to get the patient moving the knee without having any significant pain. Ankle fractures. This is a bimalleolar fracture of the ankle. On the outer part of the ankle, there'll be a plate with numerous screws. On the inside of the ankle, there will usually be 2 long screws holding that fracture in place, and these are just the skin staples that we have. Ankle fractures, it's all about elevation. You've got to keep them elevated to get the swelling down, or their toes will swell and the pain will be excruciating. So the ankle must be above the heart, kind of like this guy here. Usually you need at least 3 pillows on the bed. If they're in a regular bed on the regular floor, you can flex the knee of the bed. This will elevate it up even more with the pillows and make sure that the ankle is above the level of the heart. Fluid runs downhill, that's what I tell everybody. If they're not in a position where the fluid can run downhill, then they're not elevated. The patient will return from the operating room usually with a fiberglass splint in place. They'll be under a NACE bandage, but it will be just essentially like a cast. The toes will be exposed. Any concerns, check the dorsalis pedis to make sure we're getting good pulses. Ice on both sides of the ankle. They'll already be getting their IV acetaminophen from the OR, so hopefully that plus the other medications will keep them comfortable. But again, the whole thing is all about elevation. Wrist fractures. I guess even anybody can pick out that this isn't the way it's supposed to look. This poor fellow fell, I don't know, out of a tree or something. Someplace he shouldn't have fallen out. Same picture, just from a little different angle. Just shows you the severity of the fracture. Both bones are broken. Wrist fractures. Actually 3 ways you can treat it. Most of the time it's treated 2 ways. One, we'll put pins in the wrist, which really aren't pins, they're really small rods. And these people will come back from the operating room and they will be in a long arm cast. The purpose for the cast, even though there's pins in there, is that if you can move your elbow, you can move your wrist. The bones, if you move the elbow, the bones in the lower arm will move, the wrist can move, and if the wrist can move and you only have some small pins in there, you don't want to displace the pins. So a short arm cast doesn't work for these people. They have to be in a long arm cast. Then there's the external fixator. This is the erector set of orthopedics for any of you that are old enough to remember what erector sets were, putting things together. These people are fortunate enough to have 4 pins stuck in their arm, connected by a big adjustable bar. These people won't have a cast on because if you've ever seen one of these things, they're in there pretty tight and they're not going to move anything. The patient isn't going to move anything. I've told people numerous times that we could hang them from the chandelier by this thing and it wouldn't pull out of their arm. They might not appreciate us very much, but it wouldn't pull out of their arm. These are nasty looking. The 4 pins come halfway out of the skin and then they're connected up to the big bar. So there's 2 pins that are in the hand, 2 pins that are in the radius, and then we reduce the fracture and then we attach it to this bar and then we tighten everything down. And this is what it looks like. There's your external fixator. All these different screws are tightened accordingly, depending on what we want to do, which way we want to bend the wrist, how much tension we want to put on the wrist. And then you've got 1, 2, 3, 4 pins that'll be sticking out through the skin. And just for interest's sake, this usually stays on 6 to 8 weeks before we take the pins out, because this is used for the more severe fractures. But you can also treat fractures with plates. That is, if you're fortunate enough to get a nice young person who has only cracked the bone in a few places. If you get an elderly person who has about 20 pieces to their fracture, there's no point putting a plate on it because you can't put screws into 20 pieces. So most of our elderly patients get one of these two treatments because of the fact that their fractures are in many different pieces. All right. As far as the wrist is concerned, just like the ankle, elevate, elevate, elevate. We'll put the arm up on an IV pole, be sure that you can see the fingers, and we're going to encourage finger motion. Now, I need a volunteer. And we're going to need to record this where everyone can see it. I just want to make sure everybody can see it. That's all. I'm just going to show you when we ask you to elevate something on an IV pole, how it's done. This came up just recently. Yeah. All you do is take a stockinette that you can get from the ER or the OR. You slide it right up their arm like this to the top of their arm. You're going to hang this up on the IV pole. Now what you also want to do, as long as I don't cut Cindy's hand off here, you're going to make a cut in the stockinette. So I can then pull it out like that, and it hangs up like that. That way you can get pulses, you can see their fingers, you can see that they're moving their fingers, and you're hanging up on an IV pole. So when we ask you to hang something up on an IV pole for elevation, this is how you do it. Stockinette, cut out the hand, and hang the rest of it up on the IV pole. Show and tell is always so much better than just telling them about things. Hemovacs, other stuff that we use. When patients come back with either knee replacements, hip replacements, or some hip fractures, usually the bipolars, they'll have a hemovac drain in. It's very important that nursing records the output from the hemovac very carefully, simply because this is what I'm going to use to determine when the hemovac comes out. We're waiting for a certain drainage to decrease down to a certain point before we pull the hemovac. If we don't know how much is drained, then we don't know how much or when it can come out, and we really need to know that. If it does clot off, and sometimes it does, you can just call me and let me know. However, if the patient pulls it out, which has happened as well, you don't have to call me. You can just record the time that it was pulled out and what the output was up to that point. So I still know about where we are as far as the drainage is concerned. Dressing changes. I normally like an occlusive dressing for 3 days. This is simply to let the incision heal enough, seal itself off enough so that we can't get it wet. I've had patients who have had their grandkids with their dirty hands all over their incision post-operatively, which is not good for infection control, shall we say. So occlusive dressing for 3 days. I'll normally change the first dressing, or I'll call nursing and say, would you mind changing the dressing for me and just put 4x4s or extra large Band-Aids or something on it for me. But as long as they're in the hospital, I want a dry sterile dressing on it all the time. Again, just so fingers, sheets, things, patient's fingers can't get into the dressing. Please do not put ointments on the wound. It keeps the wound from sealing itself off. Just if you want to put something on it, put betadine on it, not betadine ointment, but the betadine solution. No ointments, please. Stuff. Everything changes when the person has a mental deficit. Now, we've already told you, they'll normally let the patients, let's say, partial weight bear when they have a hip fracture. Or we may ask that they have touchdown weight bearing for a hip fracture. And this is going to lose some of its thing because the nurse in question is not here. But anyway, so we're worried about a person who may have a mental deficit. She knew I was going to use it. I asked her permission before I did. If the patient has a problem with dementia or some other mental problem, all bets are off. You know, this patient who we would normally let partial weight bear, 50%, can't understand 50%. So they're going to stomp on their leg as soon as you let them up out of bed. So these people must be treated differently. So you say, well, why did you let this person partial weight bear, but this one can't do anything? That's part of the reason. We may need to just make them bed to chair, because we have to protect them 6, 8, 10 weeks, because if we don't, those screws are going to snap right out of the bone, as you just saw in that picture I showed you before. This was like 10 days from surgery. They let this woman full weight bear on this thing, and that's what happens. If they can get up, if they are good enough to at least pull themselves around with a walker, we can make them non-weight bearing. But if it's a mental problem, you may not be able to convey non-weight bearing to these patients. You have to be extremely careful when you transfer the patient, because if they put their full weight on it while you're transferring them, they may as well be up and walking on it. The result, unfortunately, is the same. And this was that lady we talked about before. She was allowed a full weight bear before she had any chance to heal. And the screw stayed where it was. That's not going anywhere. But the osteoporotic bone snapped right through, and this patient had to undergo another surgery. Another thing we're concerned about that changes everything is a patient with severe osteoporosis. Whether they can understand it or not, that's fine. But they still can't be allowed to put as much weight on their fracture as a person who does not have osteoporosis can put on it, because the result will be the same. The bone will snap. So we may tell them, okay, normally we'd let you partial weight bear 50%, but you have to touchdown weight bear or toe touch weight bear at 20%, because we're afraid that your bone will fracture. So you may just say, we'll drop them down one level usually. This is a patient who presented to us. She had a knee replacement in the past, but she fell and she has an osteoporotic fracture. If you look at the outside of the bone, there's supposed to be a nice white line, a thick white line here, and a thick white line, real white line here. She has neither osteoporosis. So she just snapped above her prosthesis, which often is the case, when she fell. She probably broke it first and then fell, well, truth be told. So we fixed her. We put a rod up through the prosthesis, up into her femur, holding the fracture in very nice alignment. You can barely see where the fracture line is now. Now the side view, same thing. Not to brag, but you can barely see where the fracture is. So she went home doing just fine. And she got up at night. She was supposed to call her children. Whenever she got up out of bed, she got up to go to the bathroom, forgot that she needed her walker, didn't call the children, and that is our result. What did she do? She broke right above the rod. Osteoporosis. Live and learn. Next time, these patients will get a rod all the way up into their trochanter so they can't break it. But the only problem is with that is then if they break their hip, you've got a real problem because you've got a rod up where you want to operate. But in any case, this is what happens. She fractured above the rod we had already placed. This is what we did. This is not her, because I didn't have her x-rays that I can get a hold of, but this is what we used. We used what we call a cable plate, big long plate on the outside of the bone, intermixed with cables that go around the bone and screws that go into the bone.